In today's video, we are going to talk about insulin preparations, how they differ when each type is used, and why sometimes insulin is given intravenously, especially in emergencies like diabetic ketoacidosis. If you have ever been confused by all those names, Lispro, Glargine, NPH, isopane, don't worry, by the end of this video, you will understand them clearly. So let's begin. Mainly, insulin are of four types: rapid acting insulin, short acting insulin, intermediate acting insulin, and long acting insulin. First, we will move on to the rapid acting insulin. The main examples of rapid acting insulin are Lispro, Aspart, and Glulisine. So you can remember them as LAG, LAG. So these are the insulins that act very fast. That means it starts producing its effect at around 10 to 15 minutes, and its effect is maximum at about 1 hour. That means the concentration of the insulin in the blood as well as the insulin glucose lowering effect of the insulin will be maximum at about 1 hour, and it acts up to 5 hours. These insulins are given just before meals to control the sudden rise in blood glucose after eating, what we call postprandial glucose spikes, because the onset of action is around 10 to 15 minutes. So, in short, if you inject this right before you eat, it tackles the sugar rush from your food. So, the second type is the short acting insulin, also known as regular insulin. The onset is 30 to 45 minutes, peak in 2 to 4 hours, and its effect lasts up to 8 hours. Since it acts a bit slower than rapid acting insulin, it's usually injected about 30 to 40 minutes before a meal. So, but the short acting insulin was injected just before meals, but the rapid acting insulin was injected just before meals, but here the short acting insulin need to be injected 30 to 40 minutes prior to the meal to have a to have its effect in postprandial glucose level. And one more peculiarity about regular insulin is that it is the only insulin that can be given intravenously. So, but why insulin is given intravenously? Insulin is given as IV in emergencies like diabetic ketoacidosis or DKA. But why insulin is given in DKA as intravenously? Let's understand this properly. Diabetic ketoacidosis happens mostly in type 1 diabetes when the lack of insulin is more severe. So without the insulin, glucose cannot enter the cells. So the body thinks it's starving, and so it starts breaking down fat for energy. So the byproduct of fat breakdown is ketone bodies. One of the byproduct is ketone bodies. So it releases ketone bodies into blood. The fat breakdown will releases ketone bodies into blood, which is acidic. That leads to metabolic acidosis. So in this condition, blood flow to skin and fat tissues is poor, as well as in this when ketone bodies are high in blood, it can enter the brain, and it can, if it is not treated, it can lead to coma of the patient. So it is a medical emergency, and as well as in this condition, blood flow to the skin and fat tissues is poor. So if you inject insulin subcutaneously, it won't get absorbed properly or quickly. But with IV regular insulin, the effect is immediate and more precise. That means it helps glucose in their cells stop ketone production and reverses acidosis rapidly. That's why in DKA, regular insulin IV is life-saving. And the third type is the intermediate acting insulin. The main examples here is NPH or isopane insulin. Sometimes insulin suspension is also used, and its onset of action is 1 to 2 hours, and this insulin shows its maximum effect from 4 to 8 hours, and its effect lasts for about 12 to 18 hours. So its main use is to provide basal insulin coverage, meaning it maintains steady insulin levels between meals and overnight. But here is an interesting thing. This type of insulins are often combined with rapid acting or short acting insulin to cover both mealtime spikes and basal needs. I will explain. This NPH or isopane insulin, or the insulin zinc suspension, actually it effects last for about 12 to 18 hours, but its action starts at 1 to 2 hours, so it does not give its effect after a meal. That means it is not effective in controlling the postprandial glucose spikes. For that purpose, we need rapid or short-acting insulin. So when the NPH insulin is combined with the short-acting insulin or the rapid-acting insulin, that formulation can provide both effect. It can lower the postprandial glucose spikes as well as it will cover the basal needs. That means it maintains the insulin level steady throughout the uh, throughout its duration of action. And why this is combined? Why it is not given alone? We already have said that this insulin cannot it is not effective in controlling postprandial glucose spikes. So, and as well as no single insulin perfectly mimics our natural insulin rhythm. Our body normally releases small amount of insulin all day and quick burst of insulin after meals. So combining them gives more balanced glucose control. Some of the examples of short acting with the NPH is Humulin 70/30, the 70% NPH and 30% regular insulin, and Novolin 70/30. And rapid acting with NPH insulin example is Humalog mix 75/25. So this combination gives dual control. The rapid or short acting insulin manages the glucose spikes after meals, and the NPH insulin maintains the steady levels of insulin between meals. So they are convenient because they reduce the number of injections. But the downside is less flexibility. You have to eat at fixed times or you risk hypoglycemia. And the fourth type is the long acting insulin. And the examples are Glargine, Detimor, and Degludec. So the onset of action is 1 to 2 hours, similar to uh, intermediate acting insulin. The peak is it does not have any peak. Its effect is flat throughout its duration of action. So it does not have a peak effect, which suggests a more glucose lowering effect takes place at a particular time. Nothing like that with the long acting insulin. For Glargine, its effect lasts up to 24 hours. Detimor about 20 hours, and Degludec up to 42 hours. That's ultra long acting. So these are given once daily and they provide steady basal insulin level throughout the day and night. No peaks, no dip. And that is all about the rapid acting, short acting, intermediate acting, and long acting insulin, as well as the premixed combinations of insulin that make life easier for patients who need both basal and bolus control in one shot. So I hope you found this video helpful, and if this video helped you understand insulin better, don't forget to like, share, and subscribe.